Well, I'm Brandon. I'm a doctoral student over at NDSU. I'm in my 4th year of my PhD in clinical psychology.
And I'm Katie Gordon. I'm a professor at NDSU in clinical psychology.
And our talk tonight is called Heroes Need Help Too. And just to kind of give you a little idea of what we'll be doing tonight, we'll start off just to tell you a little bit about psychological diagnoses and just kind of the process of coming to a psychological diagnosis. Then after you have that diagnosis, what's the next step? How do you decide what treatment will you administer with that sort of person? And then to kind of demonstrate the process, we'll give a couple of case examples with our 2 favorite fictional characters, Buffy Summers and then Bruce Wayne. And then just to kind of give you an idea of kind of how we got into this, and we have this blog called Jedi Council, and we've been working on this for a couple months now. And it all kind of stemmed out of, we both have this training in psychology, and we both have these nerdy interests and shared interests in some of these fictional characters, and just kind of talking. I think it started with Darth Vader after the new Star Wars movie, and we kind of talking about Darth Vader and how awesome he is, and Kylo Ren and how cool he is too, and just kind of comparing these two. And then also just kind of how can these characters be used as teaching tools too in the classes that we teach. So we thought it was so interesting and fun that we figured everyone else in the world will probably think it's as interesting and fun. So we started a blog and we started a podcast, and you should all like and follow it and give us all of your attention. So that's what we'll be talking about tonight.
So to get started, we'll talk about the diagnostic process. And mental health professionals actually use a scientific process to arrive at a diagnosis. So when someone presents with a problem, when they come to therapy, they usually have some specific reason for being there, and there's a variety of different things. Sometimes they'll just say something like, I don't feel like myself anymore, or I'm just unhappy. And other times they'll be more specific, like my partner thinks I drink too much, or I'm hearing voices, or whatever it is. So what we do in the initial stage is get some information about the presenting problem and formulate hypotheses about what might be underlying those symptoms. So for example, if someone says they're hearing voices, I might think it could potentially be schizophrenia, could be bipolar disorder, could be drug use, maybe they're using a lot of methamphetamines and having hallucinations, could be a stress or a medical problem. So I formulate those hypotheses, and then what we do as clinicians is gather data to test the hypotheses. And the way that we do that is through using assessment procedures. There are a lot of different ways to assess for mental health problems, but the 2 main types are questionnaires, where people are asked things about what kind of symptoms are you experiencing. Through a questionnaire, we score it and then try to identify if they fall within a certain range. So for example, if we think they might have an anxiety problem, they would fill out a questionnaire that asks them about sense of dread or their heart rate beating rapidly, and they rate how severe it is, and then we compare their answers to people without anxiety disorders and people with anxiety disorders. And so if they score in a very high range, then that might be what we think their diagnosis is. If someone presented hearing voices, like I mentioned before, I would use the other major method of assessment, which is interviewing either them or someone they're close to, and ask about events that might have preceded them hearing voices, asking if there's a family history of psychotic disorders or other mental disorders, since those tend to run in families. And so after gathering that data, I would refute the hypotheses. For example, if they say they've never used drugs and there's no evidence of that, then I can throw out the hypothesis that they're hearing voices because they're using too many substances. However, if there's some support that they have other symptoms along with schizophrenia along with it, such as having a lack of joy, not feeling like interacting with people, then I might arrive at a diagnosis. And so within different fields of science, most have their own classification systems. So, of course, in chemistry, we have the periodic table. In clinical psychology and in mental health, we have the Diagnostic and Statistical Manual of Mental Disorders. And it serves as our classification system just so that people can communicate with each other about what does it mean to have depression, what does it mean to have anxiety. And so once we gather information about them, then we compare what they're experiencing to the criteria listed in the DSM-5, and we'll go into more detail about what this looks like with our case examples. And the idea is to ultimately conclude with a diagnosis that can inform treatment.
So then you've got this diagnosis, and then the question is, what do you do after that? So the first thing that there's a couple of different schools of thought really. So there's one side that subscribes to this idea that therapy is kind of an art form, that you should use the treatment that you think works best, that you think is tailored to this specific client and the specific problems that they have. As taking the scientific approach that we do, we are really much more guided by what does the literature say is going to be the most effective treatment for the specific diagnosis that this person has. So what we'll do is we have this diagnosis that we came to through the means that KJ just described, and then we jump into the scientific literature to really see what's the best or most empirically supported intervention for that diagnosis. And then this literature is it can be broken down in a bunch of different ways. So starting at maybe the least impactful, you have that clinical observation. So just in your experience in the clinic when you're doing these treatments, what seems to work, what doesn't seem to work. And then going across the slide there, you have all the way down to those randomized clinical or randomized controlled trials, and then subsequent meta-analyses of those studies to really, that's going to be your most impactful or most meaningful scientific literature that's really going to guide what is the most empirically supported intervention. There's some really great resources that kind of put all this data together. That way, and I think Katie has an example a little bit later, that like websites that break down each disorder and what are the best or most empirically supported interventions for those disorders. Sometimes there are certain disorders though where you don't have a good empirically supported intervention for that disorder. So that's where you really have to take that more hypothesis testing approach to treatment. So you make this hypothesis and you form it based on the clinical observation or the available data that you do have, and decide on a specific type of treatment that you're going to try with this client with this disorder. And then the process is, just to continually collect data, assess whether or not the treatment is working, whether or not the symptoms are lifting, or the client is, increasing in their functioning, and then reassess or reevaluate your hypothesis to really determine, is the treatment working? Do I need to revisit the hypothesis, form a new hypothesis to try a different treatment? And just kind of base it on that. So when you have that nice guideline and you have the literature to follow, it's a lot more clean cut. But sometimes you have to do the best that you can, and you have to kind of take that scientific approach the best that you can.
So as a case example, I'm going to talk about one of my favorite fictional characters, Buffy the Vampire Slayer. And I like a lot of the things that many people like about Buffy, in that she's a strong person, she helps a lot of people, she's clearly a very feminist character, she's very witty and funny. And the other thing that I really like about her is that she's vulnerable, and you don't see that a ton across superheroes. And one of the places where this is most prominent is around season 5, and I'm going to talk about some things that happen, so I hope the spoiler thing is okay, because it's been like 10 years. But if not, don't listen and I'll tell you when it's over. She dies at the end of season 5.
Whoa!
I know, sorry. I know. But stay with me, because she comes back at the beginning of season 6. Okay? I know. It's very roller coaster type season. So anyway, what happens is she's died saving the world and saving her sister, and she goes to a place that she feels is like heaven. She has no worries, no stress or anything like that. Her well-intentioned friends at the beginning of season 6 use magic and witchcraft to revive her from the grave. She becomes alive, has to claw herself out of the grave. Is traumatized by that, understandably, has a hard time connecting and re-engaging in her life. So what she does is she starts kind of going through the motions. For those of you familiar with the musical episode, that's one of the songs she talks about, going through the motions of her life, but she feels really disconnected from it. And she's actually exhibiting a lot of symptoms of depression. And so, for example, when she gets back, she doesn't feel like she has a sense of direction. She reapplies to college, is rejected, and works at a fast food restaurant called Double Meat Palace, which is really creepy and not fun. She gets involved with Spike, who is a vampire, and she's a vampire slayer, so that's a problem. And in addition to that, he's actually killed vampire slayers in the past. He's also not a nice person, but because she's depressed, she ends up getting romantically involved with him because he's in love with her, and that helps her feel better. And also she says she connects with him because he's also technically dead since he's a vampire. But she hides all of this from her friends, and that rings true to depression. She really tries to keep up a strong face and attitude about it. So anyway, looking at so my hypothesis was that she met criteria for major depressive disorder. I have the symptoms up there from the DSM-5. There are 9 symptoms. And for people to meet criteria for major depressive disorder, they have to have 5 of these 9 symptoms for most of the day, nearly every day, for at least 2 weeks. And the reason that it's that way is so that people who are just sad don't get diagnosed with a mental disorder. So she shows sad mood, anhedonia, not really enjoying things the way she used to. This picture is from a scene that really shows inappropriate guilt and feelings of worthlessness. She's confiding in her friend Tara about her relationship with Spike, and she tells Tara, "What I've done is unforgivable." So it's understandable that she would have some guilt about the situation, but that extreme level of doing something that no one could ever forgive is very reminiscent of how depression works, this idea of taking it to an extreme. In addition, she has some difficulty concentrating on things, she's really self-focused, and she has thoughts of wanting to die. And in the musical episode from that season, if you're familiar with Buffy the Vampire Slayer, there is just a classic episode where there's a spell that overcomes Sunnydale, and all of the characters start singing and revealing things that they've been keeping as a secret from each other. And so I'm just going to read part of the lyrics. I'm not going to sing it, but I'm going to read it to you. Sorry. You can, if we have a volunteer to sing it, that'd be fine. But I think I'll just read it, because I think it really captures depression. I touch the fire and it freezes me. I look into it and it's black. Why can't I feel? My skin should crack and peel. I want the fire back. So it really captures that kind of disconnection. The good news for Buffy is that there are a lot of effective treatments for depression, and the process that Brandon outlined earlier has been streamlined by the American Psychological Association. So they've made it so that you don't have to just go look at all of the academic literature and figure out what's scientifically based and what's not. They've made this easy website. We're going to pass out these forms later if anyone's interested in looking at this. It's a pretty cool website. You can click on disorders and then go to major depressive disorder. And then what comes up is a list of possible treatments and the strength of the research backing their effectiveness based on the diagram that Brandon spoke about. And so, as you can see, there are multiple options with strong research support for treating depression. The therapist and the client would collaboratively decide which approach to take in light of the fact that there are multiple effective options.
All right. So, my favorite character, Bruce Wayne, Batman, I don't know if anyone's ever heard of him. Kind of an obscure character, but certainly one that I've always been passionate about, been interested in, and I'll talk a little bit more about that after we go over the diagnostic criteria. So I think when people think of Bruce Wayne, the first thing that they think of is, oh, classic PTSD sort of guy. But that's not quite the case. It's a great hypothesis, Nite support unit. But when you really break it down, PTSD has a couple of big requirements. So you have to have that traumatic event, which of course he has. He witnessed the murder of his parents. Absolutely, that's traumatic. You have to have some re-experiencing of the traumatic event. I would argue that he does experience, or does have some re-experiencing in that he has some of these flashbacks, he has some of these nightmares. He has this this bat that comes through the window that he thinks is from his father. So there's some definite re-experiencing. But the big one that we don't see with Batman is avoidance. Someone who would be avoiding in stimuli or in environments that would remind them of this traumatic event or this murder of their parents would not charge into these sort of environments, would not be trying to punch criminals who have the guns. And that right there you can kind of rule out this PTSD diagnosis. So that leads us to obsessive compulsive personality disorder, OCPD, which if you go online and kind of Google Batman psychology, this is a little bit of a different take, I think, but it really, the conceptualization really fits in my mind. So when you break down the diagnostic criteria, you have excessively devoted to work and productivity. This fits Batman really well. He foregoes his personal relationships, he foregoes romantic relationships for the most part. And he's not really involved with the family business in any way. He's really just driven. He has this war on crime. He doesn't want anyone to experience what he went through. So he's really devoted to that work. He works every night. He doesn't take the day off for the most part. So you have that work and that productivity. Overconscientiousness and inflexible about matters of morality or values. That could just have a picture of Batman's face, really. I think it's a perfect description. He has this moral code. He refuses to kill. He's not going to cross that line. If people have seen Batman vs. Superman, they could argue with me against that, I guess. But that's a topic for a different time, maybe. So, and a lot of times there's even some people who maybe argue, you know, okay, so you have the Joker. Every time you let the Joker go or you don't kill the Joker, how many more lives are on your hands because you're not crossing that line? Which is maybe a fair argument, but he won't cross that line. He just won't do it. Reluctant to delegate tasks to others unless they submit to his way. Batman doesn't have any superpowers, but he a lot of times serves as the leader, sort of, and tactician of the Justice League. He's kind of devising their strategy. He has these sidekicks of his Bat family. They're all kind of following his lead. He doesn't like to delegate if it's going to be a dangerous environment or a dangerous situation. He likes it to be kind of done his way, and his way is kind of the only way or the highway. And then last, that shows rigidity and stubbornness. That kind of fits in with all the other ones. He's very rigid in his moral code. He's rigid in how things are done, and he's very stubborn as well, just in that he doesn't really give up, he doesn't really back down. And then I think you could probably argue unable to discard worthless objects too. People who are maybe more familiar with the character, he does collect a lot of these items from some of the various super villains that he takes on. So this is kind of how I conceptualize this OCPD diagnosis. So what does this character really mean to me? And overall, I think Bruce Wayne or Batman's a really great character in that he's a good example for people. It kind of gives people something to strive towards in that he's a little bit more relatable than other superheroes and that he doesn't have these powers. He kind of trained for what he has. No one's ever going to get to this level, but it does give someone something to work towards. And maybe it is another example too of someone who maybe took a traumatic event and turned it into something more positive and tried to create a meaningful life out of something that was really damaging. For me personally, Batman's pretty inspirational. I have a Batman tattoo. It reminds me of all these values that I try to take from Batman. You know, working hard, you don't need powers to do great things, sticking up for people who maybe can't stand up for themselves. So these are just some things that I personally take from the character that makes it important to me. So OCPD, when you jump into treatment, unlike depression for Buffy, when you go onto the website here, you don't get an option for OCPD when you click on the disorders because there's not a really good empirically supported intervention for obsessive compulsive personality disorder. So that's where you have to take that other route and you have to kind of do this hypothesis testing approach to figure out what's a good treatment to work based on what I know and the data that I do have, and just kind of reassess it as you go. So one example, just to give an example, is cognitive therapy for personality disorders. There's a book and manualized treatment for that. That might be a good jumping off point. You might work with that with your client and explain that there isn't a good empirically supported intervention, but there you have some, you suspect that this might work. Agree to do that, and then kind of just assess it along the way to make sure that it is working. And if this treatment isn't working for the client, then to just reformulate a new hypothesis and try a different treatment approach. So, in closing, thank you all very much for all of your attention. I shamelessly plugged a little bit in the beginning. I'm going to do it again. Please, if you enjoyed this talk in any way, check out our blog, check out our podcast, send us an email, follow us on Facebook, or like us on Facebook, follow us on Twitter, some variation of that. We kind of conceptualize all sorts of different fictional characters. If you have a character that maybe you're interested in, send it over. It's very possible that we know absolutely nothing about this character, but that would just give me an excuse to watch an entire TV show to learn about this character that you're interested in, and then ignore other things that I should be doing. So please, if you have a character that you're interested in, send it over, and we'd be happy to take a look at it, maybe write about it. And then as far as the podcast, that just really looks at different topics and kind of integrating this psychology and this kind of nerdy, geeky knowledge. So if you have any questions, anything like that, send it over to us, and we're happy just to talk about it. Clinicians and instructors, we just talk. That's all we do. So just give us things to talk about, and we'll just keep talking. So, and then we just had, Katie mentioned that we did have a handout too, just with some of the different things that we talked about during the talk here. So thank you all very much.